Hi, greetings on World Cancer Day, and today we have a very renowned pulmonologist, a dear friend of mine with us, Dr. Prashant Chhajed, and what we'll try to do is to understand from him certain things regarding lung cancer. So, Prashant, I have few questions for you, and your answers will be very useful for the audience. So, the first question is, when do you suspect lung cancer in a patient?
See, the common symptoms of lung cancer are basically if somebody has a cough for more than 2 weeks, somebody is elderly, somebody has a history of smoking. So these are some simple symptoms where we need to think about lung cancer. The additional symptoms which we see also are if somebody has a sudden loss in weight. You know, if patient has an infection, typically that individual will have a slow drop in weight. People with lung cancer typically will have a very sudden loss of weight. Then in practice, what we see are individuals who have had a patch on the X-ray chest, have had some cough, had some breathlessness, are being treated with antibiotics, are being treated with some local treatment, and they do not respond to that local treatment. The symptoms are persistent. The opacities on an X-ray chest, for example, are persistent. That's when we start to say, okay, this individual has we look for other risk factors which may say, okay, this may not be infective. Then we start thinking about lung cancer in these patients.
Prashant, you made a very valid point. Cough, persistent, not responding to treatment, think about lung cancer. The next question which I have for you is, are there any methods of screening being followed, and which are the ideal candidate for this screening for lung cancer?
See, screening for lung cancer is is the holy grail. You know, we would really like a situation, a test which can help us screen for lung cancer, and we are able to detect lung cancer in the early stages, because typically by the time an individual develops some symptoms of lung cancer, these individuals are already in an advanced stage. So the question about screening has been in the mind of our researcher colleagues, people who are in lung cancer, for a long time. There are no definitive guidelines yet set for the screening of lung cancer. However, there are some recent trials which have been encouraging. People are working on it. In some countries, for example, like Japan, they would find out or highlight individuals who are more than 30 or 40 pack years of smoking, who are more than 40 years of age. And in these patients, they would undergo sputum cytology testing. So to say sputum cytology testing to look for abnormal cells or to look for malignant cells is one simple method of screening. However, the cost effectiveness, the impact on the mortality is still to be studied in a larger population. Once you have a sputum cytology, I'll discuss the Japanese model where I used to work some 10-15 years ago. There they would then subject the individuals who have had an abnormal sputum cytology then to a battery of tests. So what they have done is they've used sputum cytology to screen individuals and take the people with abnormal tests further for a CT scan, for a bronchoscopy, maybe for a autofluorescence bronchoscopy, etc. Now the question often came to the minds of all the people working in thoracic oncology is, how about screening for CT scans, using CT scans for lung cancer? Now there have been several concerns raised about using CT scan for screening of lung cancer. People talk about radiation, people talk about overdiagnosis, people talk about the impact on mortality. However, recently in the US, there was a large study which used low-dose CT scanning in high-risk individuals. Who are the high-risk individuals? Individuals who are more than 40 years of age, who have got more than 30 pack years of smoking. They were subjected to CT scan screening, and they found out that about a 20% reduction in mortality could be achieved if the method of CT scanning is used for identifying patients with lung cancer in the early stage. However, the long-term impacts, whether that can be made applicable on a larger scale, still needs to be seen. So what do we do in practice? In practice, we have one issue. One is screening for cancer, that is screening asymptomatic patients for cancer. And the other issue is making an early diagnosis of lung cancer. An early diagnosis of lung cancer would be when individuals have symptoms, when individuals are not responding to treatment. As I mentioned earlier, they've got a patch on the X-ray chest, then one should have a high index of suspicion. Typically, we have had a high impact of suspicion in individuals who are elderly, who have been smoking. But now, as clearly we have seen in the last 2 decades, we see a high incidence of lung cancer also in non-smokers. So we need to have really reduced our threshold to investigate and suspect lung cancer whenever we have a situation where the symptoms are not improving after regular medication. People have persistent symptoms like cough or unexplained weight loss. I think that's what the medical community needs to do.
So Prashant, you put it very nicely that there are lung cancer screening. It is very tough to implement. Usually we are not able to implement in overall population. And most important is, remember that if the patient has symptom, investigate. That was a very nice message from your side. So I'll go to the next question, Prashant. What are the differential diagnoses of lung cancer, and especially tuberculosis, which is always a problem when we want to diagnose a lung cancer? And how do you go about it in your clinic?
Yes. So I think, Kumar, what you've brought up is a very important point about how do one differentiate between tuberculosis and lung cancer. Why are we talking about this dilemma? Tuberculosis is very common in our country. It's one of the most common infectious diseases which we have. The symptoms of tuberculosis and lung cancer also overlap. What are the common symptoms in both the diseases? In both the diseases, an individual has cough. In both the diseases, the individual can cough out blood. In both the diseases, a patient can have a weight loss. And in both the diseases, when you look at the X-ray, which is the common investigation, there is a opacity or a patch on the X-ray. So there are certain things which we can do to streamline, and what we do in clinical practice is we use now tests like sputum AFB smear, which is a common test. But in addition to that, now we have molecular tests which have been made available also by the government at a larger scale, and the implementation is actually increasing. That is called the sputum TB gene expert. So if we use sputum AFB smear and sputum TB gene expert, that gives us a very good foundation to look initially and early for the presence of pulmonary tuberculosis. Now, there's one more thing which is underutilized, I would say, or not used very frequently in practice, is sputum cytology. So what we need to think is we need to see where we can place sputum cytology. When do I use sputum cytology? If I have an individual where I think, oh, this could be a lung cancer, this could be TB, and this individual has a reasonable amount of phlegm which he's coughing out, then that we would subject, or which would allow, send it for TB testing as well as sputum cytology for malignant cells. If these sputum tests are inconclusive, the very important test is the CT scan. The CT scan of the thorax is a very important test, and it helps us to understand the thorax better. And then you may have a very clear-cut mass lesion which says, okay, this is suspicious or a very high probability of having a lung cancer. That helps, and then you go for tissue diagnosis. Tissue diagnosis is very important. Or on the other hand, you may have a very classical situation of tuberculosis and say, okay, this is very high probability of tuberculosis. But in both the cases, in lung cancer, you want a pathological diagnosis. In tuberculosis, we would like to have a microbiological diagnosis. Now, what about those things which are in between? Oh, this could be TB also, or this could be cancer also. In that case, we need to do some appropriate testing based on the CT scan. That could mean just doing a simple bronchoscopy on an outpatient basis and take samples, and then we typically send these samples for testing for TB as well as for cancer. That could be a wash from the lung, it could be a lung biopsy, it could be an endobronchial ultrasound or an EBUS TBNA from the mediastinal lymph node, or it could be a CT guided biopsy, and send it for testing. The important message I would like to put across is, whenever we are not sure or whether it is that this is definitely malignancy or definitely tuberculosis, we send both, because the sample which you retrieve from a biopsy or from a procedure is very precious and should be sent for microbiological testing, that is smear testing, or for TB gene expert testing, or for TB culture, and at the same time also for histology and cytology. So this helps us to move towards a tissue diagnosis. Sometimes you have a CT scan, you're not sure, the lesion is not very accessible, maybe even for a bronchoscopy, or a CT guided biopsy, or you've just got a small nodule on the lung or on the CT scan. What do? There's an important test which is now becoming gradually more and more available, particularly in the last 5 years. That's called as the PET CT. So we do in the appropriate patient, we should do a full body PET CT scan that highlights the active lesions. Now, a PET CT scan will not tell us the difference between a lung cancer or a tuberculosis, for example, but it only tells us which are the areas which are affected, and typically it guides us to the most easy available site or the most likely site that would give us a diagnosis, whether of cancer or of tuberculosis. So to sum it up, TB and cancer can sometimes be very clear in the diagnosis. You have a simple, you do a scan, you find a big lesion, you do a biopsy, you have a diagnosis, you have a sputum which gives a diagnosis, and then in between there are situations where the sputum is not conclusive and you need to do further testing like a bronchoscopy, a CT guided biopsy, or a PET scan to help you to reach a diagnosis.
Prashant, you gave a very nice brief on how to handle this TB and lung cancer. They are common. Not all TB is lung cancer, but not all TB which looks in the scan as a TB is TB. So one should keep our eyes open, and that may help in diagnosis. So I have a last question for you, because all these patients, they come as a primary physicians to either a medicine person or a pulmonary physician. So what are the measures you think one should take at that level to ensure that early diagnosis happens? So what will be your message to those people?
So Kumar, I think this is a very crucial point, because we may have all the tools which are available, but they need to be made available to the patient in a systematic manner. So I think, what is the first point of contact to an individual? The first point of contact is probably a family physician or an internal medicine physician, who is taking care of the regular symptoms which the patient may have. So they're the first point of contact, as we would say. Now, every patient who's got a cough or a patch on the X-ray cannot be referred to a specialist, because that's not feasible. So what I would put across is that any individual, as I said earlier also, should be treated based on the merit of the symptoms and whatever the baseline tests are available and whatever is the highest pre-test probability. If the high pre-test probability of or with the basic tests done is going in the direction of particular infections, that should be taken care of. We know that tuberculosis is a very common disease, but not all TB, what we see on the X-rays TB, it could be cancer also. But we must make a lot of effort. The physician should utilize the current simple techniques like a TB gene expert, which has actually revolutionized the diagnosis of tuberculosis, even particularly in patients who are AFB smear negative. So all these basic tests like a TB gene expert, I think, should be considered in an individual who's got a weight loss, who's got a cough, who's got a chest pain, who's coughing out blood, to rule out tuberculosis. And I think in these basic tests, if these individual at a primary care level or a physician level has found out, okay, we've looked for the basic things of tuberculosis, it's negative. We've treated this individual with antibiotics, but he doesn't have the desired response. I think even a CT scan can be asked by a physician so as to not delay the diagnosis. So the CT scan is done quite quite easily, particularly in the urban places, and what I hear is more so in our second and third tier cities also. So once the CT scan is done, it opens up the thorax and gives us an idea in which direction the patient should be referred to. Once an individual comes to the physician or to the specialist, I think the job of the specialist to take on and respect whatever earlier tests have been done, then inconclusive, and take it on rapidly to confirm the diagnosis of infection or malignancy. An important message I would like to say is we need to refrain from empirical treatment of tuberculosis as far as possible. I know in today's conditions it may not be always possible, but we really need to refrain from empirical treatment, and if we are giving empirical treatment, all these patients should be under very close watch, a close clinical radiological monitoring. Patients should be informed that yes, we have no definitive diagnosis of tuberculosis, we have a high suspicion of tuberculosis, and an empirical treatment has been initiated. It should not happen that people have completed 6-9 months of TB treatment and then are referred for testing for malignancy. So the message is, if your patient is empiric treatment, he's not responding as you would like it, I think maybe we should go ahead for further testing. So Kumar, this is what I think are the important messages from a primary care or internal medicine or a pulmonologist point of view. If there are any specific questions you want to ask me on this, I'll be happy to answer them.
Thank you, Prashant. Thank you for giving wonderful comments on the questions, and I am sure audience will benefit from the comments you have made. Thank you so much.
Great, Kumar. So thank you so much. As Kumar introduced in the beginning, I'm a pulmonologist. Kumar Prabhash is a very respected and a leading thoracic oncologist at Tata Hospital. Now, we have planned this session as an interactive session between both of us. And now that I have laid down the background by answering Kumar's questions about the common points for lung cancer and how can we diagnose it early, how we can differentiate it from tuberculosis, and what simple clinical messages can be passed on. I would now like to have some questions for Kumar, which I believe will be very important for the audience and would be a continuation from where I have left. So Kumar, the question which I would like to put forth is, what are the current trends which we see in the incidence and the mortality of lung cancer? When we passed out from our medical school, the incidence was low. We were under the impression that lung cancer is more a disease of the West and infection is more in the in part of our country. So how has the incidence changed? And even from the mortality point of view, the 5-year survival has been dismally low about 20 years ago. Has that changed now?
So, Prashant, the lung cancer incidence, if we see in the overall world context or Western context, it is around 40 to 50 per 100,000, and that's primarily because smoking is pretty common there. In Indian context, it is not uncommon, but far lesser than in the Western world, and it is around 6 to 7 per 100,000 population. But because our population is very big, then overall number becomes very important. If we see in US, 1/3 of our population or less than that, maybe 1/4, they get almost 200,000 of lung cancer every year, and we get almost 100,000 lung cancer every year. So that's a big number, but incidence is lesser, but having said that, number is big. If we see the trend for lung cancer, overall in the world, the lung cancer trend, it appears, especially in Western world, and I'll say particularly in US, it is coming down. And one of the reason has been because there has been an aggressive campaign against tobacco in that country, which started around 20 years back. And because it started 20 years back, we are able to see the impact that overall lung cancer incidence is coming down. They had the smoking rate of around 50% around few decades back, which is around 16% now. So, which is good news for them. As far as India is concerned, we have not been able to see that smoking rate is coming down. We have a lesser smoking rate. Smoking rate is around 15-16% in India from the beginning for quite some time. But we hope, as with the campaign which has started in some time back, if it comes down, the smoking rate, hopefully lung cancer incidence will come down. For mortality, what you mentioned in your comment earlier was very important. We have a very high mortality for lung cancer. Lung cancer is second commonest cancer in Western world, and in India, after head and neck in men, it is again the second common cancer in India. But if you see the mortality, overall in the world, the number of people who die with lung cancer is as much people dying because of prostate cancer, breast cancer and colon cancer all put together. So, lot many people die because of lung cancer today, which we need to bring it down. For survival, yes, it has improved as compared to what it was. Till around a decade back, number of patients who used to be diagnosed with lung cancer, same number of patients used to die. But today, more people are living because of the people getting detected lung cancer earlier. So, almost 25% to 30% lung cancer patient, they get surgery done outside, which is far lesser in India. That is around 3 to 4% or 5%. And second, because of effective treatment, like putting them, doing some test for them and then giving the effective treatment, the 5-year survival, which used to be 5%, 6%, in those subgroup, it has gone up to 50%. And with the newer therapy like immunotherapy, it has gone up. So, there has been significant improvement, but overall it is dismal as compared to other cancers.
So I think, Kumar, I think you've really given us a very important view that yes, from what you said, the diagnosis of lung cancer, particularly early, seems to be improving. That is good news for our community, and surely we need to take it up further, and also the impact on the survival. There's one more question that I would like to ask you is, the Western world has been talking about smoking as a risk factor for lung cancer, and we also discuss the same thing. We talk about smoking cessation, etc. But in practice, we also see a reasonable amount of lung cancer in non-smokers. Would you like to give a quick comment before we move on to the next question on that?
A very important question, Prashant. We had our paper around 7-8 years back, where in our hospital, we had almost 40% of the lung cancer coming who were non-smoker. This was around I think so 700-800 patients data which we had, and we have seen that has continued till now. Again, we recently analyzed our data. So, we do have a good number of patients which is non-smoker. What I want to highlight is two things. When the smoking rate is less, then you do get many more patients which is a lung cancer which will be non-smoker. So, smoking rate being around 12% or 15% in our population, and 50% of lung cancer comes from smoker, that suggests that smoking is a issue here as far as the lung cancer is concerned. So, we should not take a wrong message that smoking is not related. It is related to lung cancer. In our context also, I again repeat, 13 to 14% smoker in the population, but more than 50% of those patients in lung cancer are smoker. But I do concede there are a lot many non-smoker than we had thought of, and that we need to really investigate. At this moment, investigation is on. We are up to a project in Tata Hospital to understand why these non-smokers, they get a lung cancer. There is some data from China suggesting that indoor pollution may have an impact, but that we need to prove on.
I think this is a very important point. These numbers are astounding, that 40% of lung cancer patients are non-smokers. And I think this is a message very important for our community who is watching this discussion, is that also, even if a patient is a non-smoker, you should not rule out lung cancer completely. Lung cancer still needs to be on the high index of suspicion, even in patients who may not be smokers. The next question which I would like to ask Kumar is, what can you share the patient journey from the time of diagnosis till the treatment? For example, typically when they're diagnosed with an FNA or a biopsy, and then towards the treatment part.
So, a typical patient, depending upon which kind of stage they are, we have a journey. So, if you take some early stage lung cancer patient, then you will have some symptoms where the scan has been done, and there is a patch there in the scan, and subsequently what one tries to do is to do a CT scan followed by a PET scan, or may do a PET scan upfront. Then if it is again found to be a localized disease, then subsequently if patient is fit for surgery, Then you do some biopsy to prove that this is a tumor. You also try to prove in mediastinum where is the tumor. You rule out that disease has not gone to the brain, and if patient is fit enough, they undergo surgery, and subsequent to that patient receives adjuvant chemotherapy if indicated, or adjuvant radiotherapy if indicated. If patient is not fit for surgery or locally advanced enough that surgery is not possible, then these patients, they are evaluated, they undergo MRI brain, they go PET scan to confirm that this is a locally advanced disease. They get a chemoradiation done, followed by the patient can, if they can afford, to take immunotherapy. If the patient is advanced stage disease, then in those cases, depending upon the histopathology, patient is planned for molecular testing, and we have got some name like EGFR, ALK, ROS, there are many more, but again one needs to do it to identify which specific treatment the patient needs to receive. There is nothing called one solution fit all in the lung cancer today, and depending upon these tests, patient either will receive some targeted therapy, the type of targeted therapy, immunotherapy or chemotherapy for these patients. So, at this moment there are some journey pattern for the patient depending upon which stage the patient is in initial investigation.
I think, Kumar, that's very well given in a nutshell, that based on what stage the individual has, what steps the individual may need to follow during the journey. The next question I would like to ask you is, what are the challenges faced by oncologists when you're managing lung cancer? I mean, do you miss a multidisciplinary meeting or patient forums? What are the challenges faced?
So, one of the most important challenge, Prashant, you mentioned in your comment, was that how to pick them early. In a country where we don't have a screening, what is important for us, which you did mention, I am reiterating it, that we do surgery in only 3 to 4% of our patients. In the Western world, when screening was not there, then also almost 20% of the patient used to undergo surgery, which we do understand that is the most important curative treatment available for lung cancer. Now, one of the challenges is how we don't have a screening in the community. What we need to do at the community level and at the clinician level to ensure that this surgical resection rate increases, meaning that picking them early, where we will be very happy to treat them, where we think there is a good chance that majority of these patients can be cured. Apart from that, we do have certain other challenges, that how we get the specific test done, how to ensure these tests are available to these patients at the tier 2, tier 3 and tier 4 level, so that these patients can get adequate treatment for these patients. And then another important aspect is that once we have the test, do we have the effective treatment available? And sometimes cost of the treatment becomes an issue. But good news is that there are many tests available, which is fairly freely available, which can be made freely available more subsequently. There are many treatment available, and many of them now available to majority of the patients. But sure, there are many other challenges which we need to improve upon.
Yeah. So, Kumar, you really mentioned, again, reiterated about the early diagnosis of lung cancer, and just to add a comment, now that more and more thoracic scans are being done, we are seeing more and more lung nodules which are detected, because the threshold probably to do a CT scan in the last 5 years is much lower than it was 10 years ago, and also the availability of the scanners has helped here. So the challenge which was faced also in the CT scanning programs are that you have you see diagnose many unexpected lesions, many unexpected nodules. So we are seeing more and more of those happening whenever the scans are done in our setting as well. So I think the message which I want to give across is that if a lung nodule has been identified, that needs to be taken further. It has to be seen whether this is a benign and left alone, or this is a potential early malignancy which could be incidental for a scan done for some other reason. And then there are other tests like a PET scan or a tissue diagnosis which may need to be implemented. Even if there are small nodules, now we have things like bronchoscopic techniques with radial probe ultrasound and other guided methods, which may help us to make diagnosis also in nodules which are of small size. Moving on, Kumar, I think you've covered in a very well way what is the journey of these individuals, what are the challenges faced. Now, can you tell us, what are the important landmarks that have been achieved or advances that have happened in the treatment of lung cancer and in the patient outcomes eventually in the last 10 years?
So, one of the important advances has been to pick these cancers early, especially in the context of areas where the incidence is pretty high. And for example, Western world like US and Europe, they have implemented screening, and that's why they do pick up these tumors early, and which has led to improvement in the overall survival for these patients. Apart from that, in the advanced disease setting, there has been a better understanding of the biology of the disease. So in today's time, which is a bit different from when I was getting trained, we only wanted to know lung cancer or not. Today, we want to know which type of lung cancer, small cell or non-small cell. We want to know in non-small cell, adenocarcinoma or non-adenocarcinoma. We want to know in adenocarcinoma, which is the type of mutation. We want to know subtype of mutation. And what it does, it helps you in giving those specific treatment for these patients. Apart from that, there has been development in immunotherapy in recent past. And what we have seen that because of these development, you have a significant improvement in overall outcome of these patients in lung cancer. The 5-year survival, which used to be very dismal, is better. Now also it is relatively dismal, but it is far better than it was earlier. I'll just put one number to it. If you take stage 4 lung cancer, in the past, the 5-year survival used to be around 5%. Today, it has moved on beyond 15%. So, today also overall outcome is dismal, but having said that, there are certain benefit which the patient has received with the treatment which has come in. There are some subgroup of patient which belongs to like almost 30% of them in lung cancer, that is non-small cell. If you have those mutations, then 5-year survival is around 50%, which to be again just 5% or 10% around a few decades back. So, certain segment, there has been a very important development in lung cancer in past decade, but I absolutely concede there is far more development required if we want to have lung cancer patient having a similar survival like breast cancer and many other cancers.
So I think, Kumar, that's very well put across that there are some group of individuals who have been phenotyped and then they can have a really improved 5-year survival. Now, I think the survival is obviously linked to the staging of lung cancer. And what I would like to ask you is, what are the various measures required as an oncologist to ensure early diagnosis and proper staging of the patient to improve outcomes?
So, one of the important aspect what I have learned with time in medicine is that we usually works in silo. The moment we become specialist, somehow we focus on what we do. But important is that and that becomes a big barrier in development of any a part of the treatment in any setting. I think so important should be that oncologists should take initiative to have those barriers broken. So, there is far more engagement and interaction with the primary physician, with the pulmonary physicians, with many other people who are the person who are the first contact person with the patient. Also, they need to be having more interaction with policymakers, where they are able to influence the decision making, which will be finally beneficial to this to the patient. So, important is I think so as an oncologist, we should broaden our horizon to ensure that the information which is available, it reaches far, so that it has an impact in the patient's outcome. Second will be to have the collaboration, and again collaboration with from decision makers to all other physicians. I'll say general physician, pulmonary physician, just the example, to see that certain aspect where we lack, we take their help and we collaborate with them to give answers in many situations which may finally improve the outcome of these patients.
I think, Kumar, you've said very well, the word collaboration is very important, and collaboration at different levels. But what I have seen in the city in the last 5 years is that I think the collaboration has improved. I think the collaboration between the physicians, pulmonologist and the oncologist has certainly improved. That is my perception. What is your take on it, and what do you think is the way forward? How can it be taken forward?
So I totally agree with you, Prashant. Both of us have interacted so many years. And first time we met, the instant reaction was that we need to collaborate. And I totally agree. I agree that there has been a fairly good collaboration in the city. People do interact far more than what they have been doing in the past. What I foresee or what I have observed, this has happened at an individual level. Somehow this needs to seep in more in academic centers. For example, there are many public sector hospital which caters to a far bigger number of patients which is there in the country, and this collaboration should seep in there at the level of students, where they do understand at the time of training that in the training that what you are learning is very important, but you will have the best of the outcome only if you collaborate with your peers and collaborate with your peers in a different modality. Those things I think so where we should work hard for.
Yeah, so like I think it's very well said and put across. It's called multidisciplinary working, multidisciplinary meetings or multidisciplinary decision making in the interest of the patient. So I think, we conclude our interaction for today. I thank you very much, Kumar, that, I have the honor and privilege to have this discussion with you. And what I would like to say to the audience is that I am Dr. Prashant Chhajed. I am committed to the early diagnosis of lung cancer, and I will continue to remain so. Thank you very much.
Thank you, Prashant, and thank you again. And I will conclude by saying I am and I will be committed to improving the outcome of lung cancer patients in whichever way possible from my side. Thank you so much.